Okay, we're calling the Senate Committee on COVID-19 to order. This is probably going to be our last official meeting now that we've reorganized the Senate and we have committee chairmanships. One of the things that that the health chair and I are talking about is hopefully creating a subcommittee in WAM to deal with similar issues that would comprise the same membership. So if we need to continue this, then we have some outlet. So for today's agenda, we're going to hear from the private sector, since we've had very little success in getting the public agencies to want to participate in the public meetings. So first we're going to hear from Queens Medical Center, Dr. Green, and then we'll hear from HMSA, Dr. Mugiishi. So welcome.
Thank you.
Thanks for having us.
No, thank you. So you can start with your presentation, Dr. Green.
Wonderful, thank you. It's a privilege to be with you this afternoon and share some thoughts about where we are on COVID, and I'm so appreciative that my colleague, Dr. Mark Mugiishi, is with us today. So I'd like to share my screen, and we'll start from there. There we go. Can you see the slides?
Yes.
Excellent. So we met a couple weeks ago, and I shared with you how we're viewing the COVID pandemic. So I'd like to update you and also be very open for any comments that you have or questions that you may have. So I'd like to start with, from a national perspective, I've shared just a few updates. We know right now there's a devastating surge that's going on the continent. And as we hit over 10 million people that have had COVID, and you look at the lines of the number of daily tests, daily cases, they're all dramatically going up. That third area where it shows current hospitalizations is an important one because it does show you that the pandemic actually comes in waves when you look at the hospitalizations. So as we start to talk about our specific data, this pattern you will see in our data. What's encouraging is if you look at the last, which is the number of people that are passing away because of the disease, because of the great work of our clinicians and constantly every day improving their protocols, you see from the beginning of the pandemic a substantial reduction in the number of individuals dying from the disease. So we believe that that's directly from the use of the protocols with remdesivir and dexamethasone, the kinds of medications and the ways our teams are working together across the country. In addition, I'm sharing some resources that I know you look at every day. COVID PAL is a great place to go and look for information about where we are with the number of cases. This you can look at by state or by county. It also shows you where our positivity rate is from testing and transmission rate, and we'll talk a little bit about that. In addition, I've shared the state resources, and again, we're in Tier 2 as we have not moved from Tier 2 to Tier 3 as our cases have been going up most recently. What I'm sharing right now is this is the actual data from Queens Medical Center and the patients that we admitted. And you can see early on a very small amount of patients until we start to hit July. And our surge really started right before the 4th of July, grew during the month of July, and then peaked in the mid part of August, about August 20th. That was the time that the governor did a lockdown, and you can see very rapidly the curves start to reshape and go down. And we were hitting our all-time low points in terms of the numbers of patients in the hospital, even up to 2 weeks ago, but we are starting to see an uptick. It's very small right now, but I'll talk to you about our transmission rate, and it foreshadows, if we don't manage it in terms of our health behaviors, and I'll talk about that in a moment, that we could be entering into the next phase. As we discussed last time, our RT rate, or the rate of transmission, is a very important variable for us to watch. It tells us how many people per individual are being able to, the disease is spreading to. So if you go back to September, kind of the peak of coming down off of our lockdown, you see our rate of transmission was actually below 0.9, which is one of the lowest in the country at that time. It slowly will increase, and we expected that. And what you can see between the last week is it's between 1.10 and now 1.14. If that escalates, that foreshadows an increase in number of cases. The issue right now is making sure we keep modulating it and keeping it at a flat rate between 1.14 and 1.2. We're still in a very good position. This is looking at all states across the country. We're in a very good position in terms of our rate of transmission being lower than median, but one where all of us are leaning in and saying, are we all wearing our masks? And this next slide shows you the slide that we discussed last time, which is we've been predicting a surge. We predicted the surge in the summer, and our wonderful data analytics teams are predicting one now if we don't use our masks appropriately and follow the basic public health protections. And what it shows is we go down in October, and then the surge starts in November and peaks in January, but it has a tail that can go into February and March. Now you may ask, why? Why do you think there's going to be a surge? Surges happen as everyone goes indoors, and that's why in the fall, if you look over time, pandemics have usually significantly gone up in the fall because people come in, they gather, they're going back to school, they're going back to work, and there's holidays. And those holidays foreshadow lots of gatherings. And gatherings without your masks are where the majority of the virus spreads. So as we look at it, can it happen? The answer is yes. Can we control it? The answer is yes, but it really depends on our behavior right now. This is data that shows the state reopening. This is the number of travelers, and you see as we reopen the number of travelers. I've had a lot of people ask me, do you think the surge is happening, is going to happen because of the travelers? Actually, I don't believe it's happening because of travelers, and here's why. And again, this is early data, and we're monitoring it as we go. But when you do the test 3 days before the person travels, that picks up a large number of people that have active disease and says you can't come. Then on the islands where we have been doing that secondary test, and that's 3 days after, the positivity rate with that group is extraordinarily low. It's 0.13%. That's lower than a community average, just in terms of normal individuals that are in our community. So I don't believe, and this is myself as a scientist, I don't believe that we're seeing a potential surge because of travelers. We see a potential surge because of the number of times people are coming together, again, back to work, back to school, and the gatherings. And the gatherings are probably the biggest ones, starting with Halloween, then to Thanksgiving, and then all through the month of December and early January. So this is an excellent study that was done by University of Washington, and Carl from UHERO at University of Hawaii shared it with us just recently. And what it does is it takes our Hawaii data, and this shows you the surges, and that top line is the predicted surge that folks would say, hey, without doing our interventions, here's what would happen. So it's a significant rise. That bottom data is what happens if 90% of us are wearing our masks. It substantially saves lives. So if there's one single thing we all can do right now, is number one, wear our masks, keep our distance, wash our hands, avoid gatherings. Very, very important to us. And now I'd like to talk to you about hospital capacity, but would you like to ask any questions now, or would you rather go through the rest of the slides?
Question? continue. Yeah, why don't you continue?
Okay, great. You'd asked the question of, so are you ready and what does capacity look like? This is Queens Hospital, Queens Medical Center, and it shows you from the middle of August. So where you see that top line, that's where we were at the epic top of our last surge. And we had in our hospital at any given moment that were inpatients, around 115 patients. And that meant many patients were also being transferred as soon as they got better and out of the ICU to other hospitals. And we were, as a whole health system, patients were moving between different health systems. Queens had over 65 to 70% of the patients with COVID. And particularly if you were in the ICUs, our ICUs, we had 2 ICUs that were completely full of COVID patients and a total of 6 units that were caring for COVID patients. And we are absolutely honored to be able to care for each and every patient. That was significant. And at that point in time, when we hit that peak, our nurses were getting extraordinarily tired. Our whole teams were very fatigued. We had some additional space to put patients, but not additional staff. So as we talk about what we've done to strengthen, we'll share that in just a moment, because we've been using all of this time over the last 2 months to prepare for something I hope we don't have, which is the surge, and to be more strengthened so that as a whole community, we are able to care for more patients, because that's what would be required if that next surge reoccurs. Right now we're in tier 2, and we have, just so you can know the numbers, we tend to be just below 40 in terms of our total patients, but it's starting to climb. So what have we done to add capacity? The first, really in partnership with HMSA, and again, I want to thank Dr. Mugishi. He was fundamental in providing resources to Queens to be able to do this. Back in May, our board and we were discussing what we need to do to make it safer and more effective. And one of the best ways to do that is to have a unit that is completely negative pressure and what's called AIIR. It's the highest standard of safety for patients with infectious diseases. And it's safety for the patient and it's safety for the caregivers. So our board dedicated $12 million. Dr. Mugishi donated over $1 million. And very rapidly, within 90 days, we built this unit. So we just opened up less than 4 weeks ago. Right now, the patients with COVID are in this unit. It is designed to make it extraordinarily safe. That monitor you're seeing is actually telehealth. People, clinicians can be talking directly to the patient. We can be observing the patient, and the patient can actually talk to their family and loved ones in a way that is very warm and empathetic. Everything in the room is designed to keep it infection-free. If a person's outside of the room, ultraviolet lights are constantly sterilizing the room, and all of the surfaces were designed to be completely sterile with very little trouble. And the air filtration is the safest for the patient. It pulls away the virus and it pulls it away from the caregivers. So the environment has been improved. We have this unit and several others that are already staffed, ready to go in terms of caring for patients. While we don't have COVID patients, we're taking care of everyone else. But this one in particular is quite unique, and I really appreciate HMSA's partnership and donation with us. In addition, it comes back to staffing and supplies. So related to staffing, we thoroughly appreciated the state and HHHS's support, our federal delegation in getting us additional staff. That group down below, that was the first group that came in at the end of August, gave our teams relief, and have been with us for about 90 days. The Hospital Association got together, and we have brought in another 100 that go to a variety of hospitals. And the reason that's important is it opens up additional beds. We wouldn't have got into crisis if we had the additional beds where we could have been discharging patients that still need hospitalization but are much more stable. So this is where the whole community is working together, and staffing is key. We are bringing in some additional caregivers from January through March, and we stand ready to care. Right now, we have adequate supplies for the next 90-day time period. What I'm most worried about is, given the surge that's happening on the continent right now, the ability to get additional supplies right now starts to go down. And that was what we experienced in the first part of that pandemic. We also know that FEMA is going to pull back the Battelle machine, which is the machine that's been disinfecting masks. For us, we haven't needed to use it. We've disinfected masks and put them into storage, but we have lots of private practitioners and dentists across the state that have been using it. But it will move back if FEMA doesn't change their mind the 6th of January. So we'll continue to re-disinfect masks to put into storage until that time. But we are increasing our procurement of supplies, because I'm most worried about what it'll look like in end of February, end of March. And this is the most important. I truly believe, so I shared this with my family, and I have a husband and a son who both have very high-risk health conditions. We can manage this pandemic, and we do that by wearing our masks, keeping our distance, recognizing that being in the fresh air is actually good, but keep your distance. We've got to hand wash, get our flu shots, and we need to make sure that we do not do those gatherings. So we're spending a lot of time, if you go to COVID Pal, lots of education about ways to get joy back in your life and to celebrate, but to do it virtually when possible, and safely if you choose to do it. But at least for my family, we're doing everything virtually because we can control this. But now is the time. It's the next 3 to 4 weeks that will make a difference in our community. So that's where the message I leave with you is, while it can occur, I believe we have the ability to control it. And the control comes from over 90% of us, and really that means all of us having a mask mandate that we wear it all the time when we are not in private rooms, that when we are in any kind of setting, we are wearing our masks. So I appreciate your time, and I believe that Mark will be going next. If you want to wait for all questions, or would you like me to take questions at this time?
No. Yeah, we'll circle back after the presentations.
Great.
So thank you very much. Okay, Dr. Muguishi.
Yeah, thanks very much, Senators, for having me, Jill. Thanks for including me in your time here. So I am going to share my screen as well. And I am going to okay, just making sure everybody can see that.
Yes.
I'm going to break up my presentation into 3 parts. So the first part is just reinforcing Jill's message, which, you know, she very eloquently and comprehensively went through, but I just want to reinforce it because it's really the most important thing. Then I was going to talk to you about some of the broader impacts that COVID has had on healthcare. And lastly, your staff was kind enough to forward some questions over that you had for me. So then I'll go through those so that we can answer those questions, and then you can ask any others you have after that. So based on what you heard from Jill, there's no question that our priority right now has to be control of the virus via personal behaviors. So personal behaviors are exactly what she talked about. It's wearing of masks, which, you know, a mask mandate is really something that we can do soon and quickly. And so we should do it. We should definitely have consistent mask mandates across our states so that people can be educated and will wear masks. We have to avoid gatherings. And, you know, let's just face it, we know people have some COVID fatigue. We're not going to stop every gathering. So not all gatherings can be treated equally. So if you're going to put 5 people in a room together to have a meal, do a bento instead of a potluck. Make sure people are wearing masks, when they're not eating. Do it outdoors. There's just ways to make even any kind of gathering safer. So let's do all of that. Let's have good public policies, and that's what I was talking about, the mask mandates. Let's make sure we've built the health infrastructure. That's the point that Jill was talking about, contact tracing, and making sure we have adequate amounts of contact tracing, making sure our testing is well taken care of, making sure we have quarantine facilities for people who have dense living situations so that they're not infecting their family or other cohabitants. And then really, really important, we have to have effective communication, because having all these ideas in our head, is that and $2 gets you a Starbucks coffee, right? You really need the ideas to get into the behaviors of the people that live in our state. And so having effective communication is really, really an important thing. So this slide really is just piling on to Jill's very, very well said messages, which is that we are looking down, winter is coming, as they said in Game of Thrones. That is a dangerous thing, but we actually do have the ability to control it and to mitigate the impact that might have on us, and we should take advantage of that. Now I'm going to move to some of the other impacts that COVID-19 has had on health and healthcare in our community. And here are some of the key ones. Number one, it's strengthened the mandate for affordability. It's accelerated the need for clinical integration. It's heightened the demand for value-based payments to a broader audience. It's led to a rapid and widespread adoption of telehealth that hopefully will be permanent. It's shifted health plan membership from overwhelmingly commercial to a much larger percentage in Quest integration. And it's going to require enhanced leadership roles of the people who work and live and lead our health plan and health ecosystem, as we develop public policies. So let me just briefly touch on each one. So this is no secret to all of you senators, but we have the nation's weakest economy. That's just a fact. Well, us and Nevada, we're kind of closely tied, but that's kind of the eighth island anyway. But the bottom line is we have a lot of economic troubles with us today, and they will persist with us for at least another couple of years as we try and recover. And so that means that the affordability of healthcare is all the more important. It's always been important because we spend 17% of our GDP on healthcare, but we now have a significantly depressed GDP. So we can't spend all of that, the same amount of dollars on healthcare as we did before. Employers don't have the money to pay for it. Members don't have the money for the cost shares. The delivery systems are struggling because they have to make additional investments to care for people, but they're getting less revenue. It's a problem all the way around. So the need for affordable healthcare has never been a bigger call. So we need to pay close attention to that. Part of the way you do that is you clinically integrate, which means everybody works together. HMSA is in the middle of this, not because we're the center of the universe, because that's definitely not true, but we hold the financing dollar in the sense that the government for government lines of business and employers for Quest give us the money, and then we have to kind of disperse it outward to fund the care network. And if everybody is aligned in this integrated care network where you have all of the traditional delivery systems like hospitals, like primary care providers, like post-acute facilities, like ancillary providers, and then you have the communities, things like IHS, and even the broader social determinants of health, Aloha United Way, any of those things, all integrated, trying to care for the member across, or the patient across all aspects of their healthcare journey, then you can actually leverage that dollar to help care for them and create better health within our community. So this is important. So that has meant that there's more of a demand now to pay for these things rather than in the traditional fee-for-service way, where we pay for services one widget at a time, in more of a comprehensive and value-based way. Let's pay for an outcome. And this has been, the numbers on the left of the chart show that it's been a trend altogether where it's people have believed that it results in better quality of care and it's more affordable and coordination is better. And so that's been happening, but there have been some barriers to it becoming more broad, and that's been basically willingness of providers to take on financial risk, interest of providers, and then their ability to operationalize these things. Well, COVID kind of knocked those barriers down. Now all providers really want this, because they determined during this COVID pandemic that it's not efficient to have their financing be based on an individual visit, that somebody has to come in person. And that really, if they want to provide better care for the whole community, they'd rather get paid in a value-based way so that they can deliver that care in the most appropriate manner that the environment requires at that point in time. So this is something else that will happen. And a perfect example of that is telehealth. So there's been a rapid increase in adoption of telehealth. These are some of our HMSA statistics. You can see when we first started, we were doing about 10,000 telehealth visits per month. And during the pandemic, it's gone to 6 figures. We're in the hundreds of thousands now. You see in September, there's been a slight decline as we had a little bit of a lull there and people started going in person for some visits. But we believe that over time, this is not going away. There's going to be a continued push for telehealth, and that's a good thing, because this will improve access, especially to places like the neighbor islands where you don't always have good access to certain types of specialty services and others. If we can deliver those via telehealth, that's a big win for the whole state. And finally, what we see here is some membership shifts. Commercial was a large portion of, this is us at HMSA, they were a large percentage of our business. That's been whittled away such that now our about a little over 5% of our commercial membership has migrated over to government lines of business, specifically our Medicaid or QETS integration services. So that's been growing at the same pace as commercial has been going down. That's going to put more burden on the state to fund this. It's going to put more of a compelling mandate for us in the delivery system to care well for the QETS integration patients, which we always do, but sometimes with less dollars, because the financing per member per month payment for a QETS member is less than it is for a commercial member. That's just kind of a financial reality, and so we'll have to become more efficient in all the ways that I described before. And one of the things I wanted to share is an understanding of what COVID-19 has done to kind of the economic healthcare revenue and expense financing model for healthcare. So the green line is the revenue baseline for revenue that's coming into healthcare. And you can see that it started at baseline, and as soon as the pandemic hit, it started to go down. And this is because you start to lose the ability for the commercial sector to fund a lot of healthcare as they were laying people off and we were getting unemployment. And the number of commercial lives that are getting funded by the private sector is decreasing. It was buoyed up a little bit by the federal enhancement dollars, the PPP loans and other things, but you see another drop as the PPP loans kind of went out. The green line continued to fall. As we recover, you're going to see it slowly come back, perhaps, but it will always be below baseline for the reason that I showed in the previous slide, that more of the membership has migrated to QETS, and there's going to be a lower revenue generated per member for QETS. So revenue will be depressed for a long time in the healthcare sector. Now, what's happening on the expense side? Well, initially, it actually went down, interestingly, because our partners in the delivery system, in order to make sure that they were going to care adequately for people who were getting really sick in the beginning portions of the pandemic, actually stopped doing elective procedures so that they had capacity in their healthcare area. So there was definitely a decrease in the expense, but as we got control of the pandemic, that came back. So they now had both the deferred utilization cases that haven't been done coming back, plus care of COVID patients plus the enhanced expenses for things like testing and other expenses that we're having to care for with the COVID surge that we're having. So that goes up. And again, as we get control of it, it's going to come back down. But then it will once again come back like all utilization does as pent-up demand returns. And then we have to make sure that there's a buffer for any second or third wave of infections that may happen in the winter. So you can see we're going to have, over the long haul, an increase in expense with a decrease in revenue. So this will put a lot of pressure just on healthcare financing in general. And what's coming from Washington? Well, we don't have a crystal ball, so we don't know exactly how it's going to end up. Kind of depends on what happens with the election in Georgia for the 2 Senate seats and other things. But right now, if you were placing a bet, you would say probably what we're going to end up is with a moderate president and a narrow Republican majority. If that's the case, probably the impact to healthcare is that rather than some type of massive transformation in the way healthcare is delivered, there will be tweaks and modifications to the ACA to cover the needs of the people. And that will probably be the path we take versus fundamental reform. And the things that will actually pass and happen are bipartisan initiatives, which are have been over the last year, things like transparency. So you'll start getting price transparency to consumers and to employers, affordability, especially when it comes to drug pricing, and addressing of costs that are out of control of members like surprise billing. So expect to see more of that coming. In terms of whether there will be further bailout money, that's anyone's guess. I would suspect that something will happen, but what that is exactly is hard to know, and you guys probably are more versed in knowing that than I am, so I won't comment on that. And finally, I'll just say that leadership matters. So given that this pandemic has placed health at such a high level in how policy is decided, we have to ask ourselves how health plan and health organization leaders can work together with state decision makers to shape and influence policy. And actually, I think we've done really an admirable job on both sides of the fence in doing that and listening to each other and taking all the different perspectives into account. We just have to keep improving on that and getting better at it and trusting each other and doing what's best for Hawaii. So I look forward to continuing to work with everybody on that. And finally, there were some questions that you sent ahead of time, and I'll try my best to answer these. I'm not an expert at all of them, but I have some thoughts. And so when might a vaccine be available? I don't have any more insight into this than what you currently read in the media, but I'll just say it looks like with the good news coming out of Pfizer and Moderna that probably a vaccine might get an emergency use authorization from the FDA in this year, in 2020 sometimes, and if not that early, 2021. But after that, it's the tyranny of the reality truth that you have to manufacture millions of these things, which brings up, the manufacturing of all these things brings up all kinds of supply chain issues like, do we have enough glass vials to put this thing in? And the answer right now is no. So people are like frantically trying to manufacture all the things that you're going to need to create enough vaccines to distribute across the country and the world to adequately to vaccinate people as needed. So we're probably going to get something early in 2021, not anything meaningful until later in the year. And then there will be the issue of what percentage of the public is going to be willing to do it. The latest polling shows that it's a pretty low number, but it is early. I think more safety data will come out that may change that number. But right now, I'm seeing numbers like 30% of people are saying they would be willing to go out and be in the first wave of people get vaccinated, and that's not enough to get herd immunity. So we'll have to keep, again, this will be another place where there's a lot of education to be done and work to do together as a community to make sure that we do that. The next question is there a plan in place for who and how each group will get vaccinated? The answer is yes. And in fact, your government agencies are doing a really good job of trying to plan for this. I think there's a task force right now with the Department of Health and the Lieutenant Governor and others within the state agencies that are including private sector people. Like one of our experts from HMSA is in that work group, who are working on how this will happen. They're basically not reinventing the wheel. They're following the national guidelines as published by the National Academies of Science and Engineering and Medicine that have a tiered system for who gets vaccinated first. And that would be in 1A, it would be mainly the high-risk healthcare workers, and 1B would be the high-risk people, nursing homes, people with lots of comorbidities, that sort of thing. With the way we think supply chain is going to come out, there probably won't be enough to even vaccinate everybody in 1A when it first comes out, but that's where we'll start, and we'll do the best we can there, and then move through the line after that. The next question is there any indication that this virus has taken on different strains like the flu that may be with us yearly? Really early to tell, but so far so good in the sense that obviously all viruses mutate to some degree, but it looks like so far this virus has mutated in the portions of the DNA strand or RNA strand that are not the ones that our testing or therapeutics attack. So we don't have to have a different set of tests or a different set of vaccines or a different set of therapeutics to treat this as of yet, not in humans anyway. There are some animal studies that are showing some types of more significant mutations, but no data as of yet if that's going to apply to human beings. So far, so good, but it's really early to know on the mutation question. The next question is, we've been told that we have adequate testing capacity. What is the most effective testing strategy moving forward? So I would say we have adequate testing capacity for a diagnostic testing protocol, which is what we use today. So a diagnostic testing protocol is somebody is either symptomatic, or maybe they were in close contact, or maybe they got exposed, or maybe they went traveling and so they're at higher risk. How do we test them? That's a diagnostic strategy, because you're taking a group that's more likely to be positive and then testing them to see if they are or not. So in that case, what you're looking for is the characteristics of that specific test. What's the false positive rate? What's the false negative rate? Is it accurate? So we can know for sure if somebody gets the diagnosis, if they're at high risk. Right now, we're really good there. We do a good job. Our local labs have stepped up, both clinical labs and DLS, and we can do most of these things in 1 day, sometimes 2 days, at the outlier 3 days. So we're in that range, so that's good. That is not the most effective testing strategy, in my opinion, because you're going to get different opinions. In my opinion, that's not the most effective testing strategy for controlling the disease over a long period of time in a population. Because if you're looking for population control, there are things that are probably more important to a testing protocol than the accuracy of the individual test. And those are things like how much access do people have to frequent and repeated testing? Can you afford as a population the numbers of tests that you need for frequent and repeated testing? And what is the time from the sample to the result? Because if you're really going to control it in the population, you can't wait 3 days from the time you give the sample to get the result. It has to be 5 minutes or 1 minute or something, so you can immediately and effectively act on a positive test. So as we look for a testing strategy that is inexpensive, cost effective, has massive accessibility, so we can get it all over the place, has the ability to be repeated over and over and over again frequently, and therefore, and has the ability to roll out a result really quickly. You can imagine a testing strategy that could be used to send people back to school, back to work, into a nightclub, to a football game, all kinds of different things that would be effective to help us get back to life. So that's the wish list for an effective test strategy. We're not there yet. We need better technology to do that. we need funding from the federal government, and then we need local municipalities to start thinking about how they would effectuate a strategy like that for the logistics, because it's not just the test, it's the infrastructure to administer the test and then to roll it into a centralized database so that you can collate all that test and make intelligent population health decisions on all that data in one place. So it's kind of a, it's kind of a ideal state testing strategy, but for sure, in my mind, something that we could get to in the next 6 months if we put our minds to it. And then that kind of also helped answer about how this data can be most effectively collected, analyzed, and used to contain a surge. It would need to be population health based. It needs to be centralized. It needs to be actionable. And then if we work all together, I think we can do this. So with that, I know you probably have a lot of questions for Jill and maybe a couple for me. So I'm going to stop sharing my screen so that we can interact with you folks.
Yeah, excellent question.
We have questions. Senator Keokalole.
Thank you, Chair, and thank you both for joining us. Dr. Hoggard-Green,
Yes.
thank you for your presentation. You know, I personally, I would attribute a good deal of credibility to your projections, because if you're wrong about them, then it's your facilities and your staff and your people who will be exposed to risk if the surge comes sooner. And if there's no surge and this is all going to disappear, like some people in the community believe, then you've spent a whole lot of time and effort preparing for services that you will not provide, and that'll be great. But I think that what you're sharing today, because of the lack of a discussion about it up to this point, and I think our fixation on the reopening and the Trans-Pacific pretest program seems, in my view, to be rather provocative. I mean, you're projecting a massive surge after the holidays, and I really just have not seen a discussion about that potentiality up until this point. And so that's not your fault, and I appreciate the data that you're presenting to us so that we can take action on it and have a discussion throughout the community on it. But in your own defense, can you go through the methodology on how you came to these projections? And do they account for the current disease activity on the continent? Because I know that's going to be the immediate question everyone will have.
So our team uses epidemiological models that are utilized by groups like the University of Washington, HIPAM, the group at University of Hawaii. So we're using a series of assumptions about how disease spreads, population, and generally past pandemic curves that, again, really show that fall is a pretty important time. So our models are pretty consistent with what you'll see if you look to HIPAM or University of Washington. There's about 8 different organizations and many more that are doing modeling. We're all sharing the same kinds of data sets. So each one, this is a model, so it may not be accurate, but our teams use our own data and then feed it in, and any additional variables we see, we feed them in. What really drives the increase is the number of people gathering. So it comes back to so when you say, why does it look different in lockdowns? Well, in lockdowns are times where no one's moving, very few people are gathering, and you are staying within your bubble. The bubbles in the fall get bigger, and if you think of how people have joyous times, they go to football games. Some of us like basketball games better than football games, but you go out and you do things with people you love. You have parties. We know with this disease, it transmits. It's very easy to transmit it if you're not wearing your masks and you are not keeping your distance. So the reason we share the data is that's what it would say if you were using the models of what happens in pandemics and with viruses that spread through droplets or aerosolized. What we also know is you can shift that. So I think what you've been hearing, I know in healthcare we've been talking about it a lot, and all of our focus has been on educate everyone that the most important things are, please use your masks, and how best to do that, and how best to not have gatherings. So we've been focusing on the policy side of these are the things we can do to control it and not have it.
So I think.
Can I just add to that as well? If you
Please.
don't mind, Senator. So I want to agree 100% with what Jill just said and just reinforce a couple of points. So we have been within the healthcare space talking about this a lot. We are all worried about the winter months because of the indoor gatherings and the fact that there are holidays and things like that. On COVID POW, that all of the healthcare or many of the healthcare representatives sit on that, and we've been talking about public campaigns to educate and guide people, because the scientific way to look at it is that there's that one number that Jill presented, the rate of transmission. That is the number that guides what you expect to see in a surge. If it's what it means is that if it's greater than 1, it means one person is transmitting it to more than one person. If it's less than 1, it means one person is transmitting it to less than one person. So you can see how you can control a disease if the transmission is less than 1-to-1, and you can see how it gets exponential if it's more than 1-to-1. So that is controlled by both the infectivity of the virus, but also of the personal behaviors of the population that it's sitting in. So when the RT gets higher is when there is not mask wearing, when there is not control of gatherings, when there's a lot of unrestricted movement, and then that's when you get the higher RT, and that's when you get the surge. So we have been trying very hard, and it's a hard job because communication is hard as it is, and when you have COVID fatigue, it makes the messaging even harder. But it's just something we just have to keep trying to message to the people of our state that's the important thing to focus on.
So I appreciate that, and so I'll be clear about why I'm alarmed here. I think that the healthcare community and the both of you in particular have done a great job over the last since the summer in articulating the cause and then the interventions, right? We know that transmission is caused from gatherings, close, unmasked, indoors, large groups. And then the intervention is to do all of the things that you folks have so adamantly been bringing up. But I think up until today, what we have not seen is the effect. You guys are now presenting a cornerstone Hawaii healthcare institution is projecting via the data, their data, the effect, cause effect, and then the intervention. And we got 3 weeks until Thanksgiving when, this whole show gets rolling if we're gonna end up in the outcomes that are being projected. And so I think that's what's critical here and why I'm a bit alarmed that we haven't had this discussion in the public space. Again, it's not necessarily your fault because you folks are private entities, but that's why I want to make sure that there's an understanding that the assumptions that we're operating off of are based in the data and the sciences you folks have put them together. And you've discussed, so the next question, and then I'll let other people talk, is you've mentioned your own individual communication plans, and the private sector has come together to put together COVID POW. What should be the state's role in this? What should be the state's communication plan in this going forward? Because that's not within your control.
Yeah, thank you for asking, and Mark, you can jump right in, because you do have a role, a very powerful role. From a policy perspective, and Mark said it earlier, we need a mask mandate that's very simple and straightforward that people all would be doing. If we were all doing that, we wouldn't be having a conversation because we'd be seeing we wouldn't be worried about a surge coming. So from a public policy perspective, you have a lot of influence on what behaviors we should be doing as a community, and we'd highly encourage you to do that. Also, the continued conversations about gatherings, and what's important there is we know people are fatigued. So with the pandemic, and they need some joy. So we're going to do everything we can to think of ways that they can be celebrating that is safe, i.e. virtually and others. But you are in an ideal position to educate about this is something we can control, and together we can make this happen. So I look forward to continued focus on the policy side, because I believe that that will be helpful. Mark?
No, I agree 100%. I would just say, when I was a surgeon, and it's a little embarrassing to say this publicly because I don't know if and I know we're being broadcast, so, but we used to always say that perfect is the enemy of good. So if you sit there and you obsess over one single stitch, the whole operation could fall apart because you're obsessing over this one little thing. You got to kind of get on with it and move, because the ultimate task is to get to your end game. So I think one of the things the government can do is, because the government's another one that obsesses over perfect, and sometimes that is the enemy of good, because you want to make sure that you've taken every risk out of every action you do, or that you include every single perspective before you move in one direction. So as Jill mentioned about the mask mandate, right? I think we need one mask mandate. I think it's not going to make every single county exactly happy, exactly the way it's written, but we need one so it's easy to communicate. I think when it comes to communicating out about what we need people to do, like the DOH's website, they are now putting stuff on their website that's really useful. Like they recently put out a cluster thing that explained how clusters happen and how people get infected. We need lots of those. And so I know that if you want to make it perfect, you can put one out every month. Like, let's put one out every 15 minutes, even if it's not perfect. So that it's just kind of, you're getting to the end game rather than worried about each little widget as part of the plan.
Thank you.
I just wanted to clarify, Dr. Green, the committee actually had a meeting with the Attorney General, and it was in a previous broadcast, and the committee called for a statewide mandate on masks, wearing masks. And at the time, the Attorney General had told the committee that it was unnecessary because each county had a mandate. So our understanding is that there is a mandate, but it's currently organized at the county level in each of their emergency proclamations. Is that, do you believe otherwise, or do you think that that's incorrect?
I believe that you got accurate information. Here's the nuance, and I think you're doing everything you can. The nuance is it needs to be simple, and so those variations that happen across our communities make it more difficult for anyone to implement effectively, and particularly for individuals going between the communities. So I believe that you are a very effective body. I think what would be helpful is continuing to say throughout the state, everyone wear your mask, and use your wonderful leaders. You are respected. Continue to just educate that is singly one of the most important things we could be doing, and to try to keep people on point about, we are one of the few in the country. I look across the country, I have a lot of colleagues in different states. It's devastating, and they've got all this polarization in their communities where government and health providers are not doing what we're doing here. They're not working together. We are. So the more you can send the message of pay attention, take care of your ohana, wear your mask. This is all about caring for yourself and your loved ones and your neighbors. And most important, you can also share it's caring for our nurses. I know if I'm here representing our clinicians, as Mark is as well. If our nurses were in front of here and they are out telling their neighbors, please do this. It will improve your health, and we can control this disease.
Yeah, I think the committee shares your concern, especially in the sense of getting consistent communication in each county and the state. That's one of the reasons why we wanted the mask mandate statewide, as well as consistency on penalties. I think that seems to be what the real crux of it is that the penalties are not consistent. One of the things that the committee wanted to try to push for at the beginning was mass texting. So that a lot of the things you're saying, similar to when there's a natural disaster, a flood, or the case, everyone gets a text. Other counties, other cities, other countries have used mass texting to communicate to the public about COVID. Unfortunately, Ha'ima decided that that's not a tool that they wanted to use during this pandemic. We're hoping that they're going to reconsider that, especially for the holiday surge. And that's the kind of information that if we can get people if we can get government to constantly communicate these things. I mean, both of you have said we're in, to some extent, spitting distance to get to the point where we may have a vaccine. And so government is probably going to have to pull out every stop so that we can get there safely with the least amount of damage to our state, both physically, economically. And so I'm just hoping that the administration reconsiders some of these tools so that we can actually do some of the things that you guys are talking about.
Thanks, Senator. I think that's super wise. I would say in this particular case, it's impossible to over-communicate. So whatever influence you can have in increasing communication and the tools that we use to communicate, the better.
Thank you for that. You know, I just wanted to, well, I have a couple things, but to add to what Senator De La Cruz is saying, and with you just repeated, over-communication on this issue is never enough. And I think if, as our partners here, even HMSA or Queens, in your own capacity that you may have access to your patients, your staff, et cetera, and to start sending those messages out in mass texting, because we have tried on this level. We don't always get the ear of the governor, and sometimes mixed messages do happen. So also what Dr. Green said earlier is that the COVID fatigue has set in, and people are wanting to be free and be able to do what they do. I think part of that is due to the fact that we are now reopening to tourism, and our local people are getting the wrong message that because we're opening to tourism, we must be better. But that's truly not the case, in particular because now we can see where the continental United States is having high surges again, and it's just a matter of time before that is going to be here. You know, also as a result of us reopening, it's probably going to be quicker, and we are not yet 6 weeks out or so from the Halloween groupings. Then we're going to have Thanksgiving gatherings and Christmas gatherings, so I can see where all of this, us surging again, does come into play with the charts that you guys have shown us. I think just the lax attitude of our community and the mixed messages and not enough messaging is probably something that we should really, really pay attention to. And I do agree, and thank you guys both so much, because as our partners, it's so reassuring to know that we're trying to be on the right track. We do follow what you guys are saying to us. It's just getting the message out is so difficult, and we are not always on the same page with the agencies that we have to deal with. On another note, I think also the fact that they're saying a vaccine is not too distant in the future might have mixed messages for the community, saying, well, okay, if I get it now, I should be able to get a vaccine soon. But speaking of vaccines, I'm not sure if you guys are playing any part in determining how vaccination will happen, because that is going to be a real challenge for us to make sure it does happen, and in a timely and organized manner. So I don't know if you guys are working on that at all. I'd like to know. So.
Sure, I can address a couple of points you made, all of which was spot on. First, on the business sector, helping to take the responsibility of communicating out, just because our employees alone are a large percentage of the population, right? So if we're communicating to our own teams, that's going to make a big difference. So the Hawaii COVID Collaborative, which is the base organization that launched COVID POW, we're all, there's more than a dozen or so big companies affiliated with that, and all of us are committed to using our platforms to communicate to our employees and our customers. Also, I know because of my membership there that the Hawaii Business Roundtable and the Chamber of Commerce are also launching comprehensive communication plans over the holidays to beef up communication to their member organizations to make sure that we have this communication broadly spread. So, the business community is going to try and join forces with the state government agencies to communicate this as broadly as possible. And then for your question on vaccines, yes. So as I mentioned in my presentation, we have a combination of the Lieutenant Governor and the Department of Health setting up a task force for making sure the vaccines are rolled out in an intelligent way. Dr. Brian Wu, who's our local kind of savant expert on vaccinations and all things COVID, is on there, has the ability to have a lot of input. He's bringing both the scientific and the HMSA perspective to that organization about what we can do, what logistically is possible to do, and all of that, so that we make sure that we vaccinate as many of the people as we can. I think, again, I'll reiterate the two big obstacles that I see are obviously one, access to enough vaccines, because Hawaii is going to get this much of the allotment across the US. That's number one. But number two, and maybe the more pressing one, is what's going to be public willingness to get the vaccine. And that's something we're all going to have to share responsibility in another education kind of initiative.
Thank you. Just a follow-up question also. I think the Pfizer vaccine has been out in the news for the last week or so, but it also talks about how it has to be stored, and I don't think we're prepared at all to do that kind of storage. But how do you see that rolling out? Is that the vaccine that we would like to go after? Because it's probably going to be the first one coming out.
I think that may be one of the first ones. So obviously we would take our allotment of the first ones, and the Moderna one will come out very similar in timing. And it's a similar vaccine in that the Pfizer and the Moderna one are sequenced vaccines. So you actually have to get two of them about 3 weeks apart, which is going to raise another issue of compliance. Like after you get the first one, will the person get the second one? There's all these other issues that will come up with all of it. And the storage, like you say, is it's a very important and relevant point, that it has to be stored at very extreme cold temperatures that I think for sure individual practices will struggle with, but I don't think that'll be a struggle for big pharmacy chains and things like that to store it. So I think we can be prepared for that type of storage logistics.
Thank you.
Senator Moriwaki.
I really appreciate both of you making these strong statements on prevention, but I want to go back to your slide on availability, accessibility, affordability of the treatment on those who are infected, or even in terms of testing, and some of the areas that you talk about of value-added payments. If you can talk a little bit about how you see that playing out and what policies we might put in place, because we are facing a $1.3 billion deficit in the state. So, we can say, yes, we'll pay for all these services, but, we don't have the funds. How might we do that more strategically in terms of policies or any other programs you see?
Yeah, I think, and your Medicaid program is kind of starting down this path. We're still waiting for the new Quest RFP, but in the last one, there was an entire section on how the state could purchase value-based services, meaning that rather than paying for fee-for-service, they would pay for outcomes over broad swaths of the types of health outcomes they would want out of the plans that bid for Medicaid, to be in Medicaid plans. That's the type of policy that I think is a good thing, because value-based payments mean that the purchaser, which is the state, the intermediary plan administrator, which would be somebody like HMSA, the delivery system, which would be somebody like Queens and Dr. Jill, and then the member or the Quest recipient beneficiary are all aligned in what has to happen. You know, for this amount of dollar, we want to start here and end there. This is the outcome we want to measure, not how many times somebody goes, but what's their health with regard to this particular outcome. And so if state policy was aligned toward that type of integration, that type of value-based purchasing, that's a good thing. So that's the kind of thing we work with, and we work very closely with Judy Moore-Peterson and all the rest of the people in Medicaid services to make sure that we're heading in that direction. You know, and obviously, separate from the government, we work in the private sector directly with healthcare providers like Queens to say, hey, how can we pay in a way that makes sense? Because what we really want is not the number of people who go to the hospital and the number of people who get admitted, and we want to pay you for that. We want to pay you for, like, how does Queens and HMSA together make the population of Hawaii more healthy? And how do we take care of their health, whether they're sick or well? And we talk about that all the time, and figuring out a payment model that incentivizes that and rewards people for that. And Jill, maybe you can talk about it from the provider side.
So do we have, do we have that kind of model right now on how we provide those services that are value-added services or outcomes of the patient? And what would you do, for example, in mental health and substance abuse, where they're probably the most expensive services to be provided? Does it come through? So do you have that kind of model? So especially in the more expensive services, I would think in mental health, substance abuse, and how would that play out in terms of your value-added outcomes?
Yeah, no, I'm trying to let Jill answer, but I think she's struggling with her microphone. So. Still can't hear you, Jill. Sorry. Oh, there is that. Can we hear you now? Sorry, yeah. I think they're trying to fix Jill's microphone. So while she's doing that, I'll answer some of your questions. Yes, there are such models. They're not that sophisticated yet in Hawaii, although, you know, I think you saw in my one slide, I said the barriers have been alignment between the provider entities and the payers like us. COVID has not done a lot of good things, but one of the good things it has done is it's aligned us better at that. Like it's made us decide, let's figure out better ways to do this. One example is when it comes to mental health is paying for telehealth has been a big benefit for mental health because the #1 increase in the use of telehealth services has been around behavioral and mental health. That has been thousands of % increases in the use of that because people can now access behavioral health providers. They can access them from the comfort of their and privacy of their own homes, and it can help them from escalating what we now consider mild to moderate behavioral health issues like depression, anxiety, into something much more serious, like if they became, you know, suicidal or truly like in areas that really need big, major inpatient interventions. So yes, there are models. No, they are not mature. We need to continue working on them to do it. The more, you know, the government is paying more and more of the premium dollar as I showed you. And so the more government policy is aligned with what we're trying to accomplish, I think the better it's going to be for the eventual outcome.
So what about in terms of meds and substance abuse? And those are not, you know, you can't address them with telehealth. I mean, you actually have to have costs. COVID, yeah. In terms of, COVID as well. Treatment.
Yeah, I mean, you know, obviously there will always be need for tertiary and quaternary care for people who are very, very sick. There's no question you need that. And really, the only thing you can, and those things are expensive. And the only thing you can do to lower the cost of care for that is to reduce the number of people who move from one level of care to the next. And that's why the value-based care is important, is because that's what it does. It tries to put out the fire before it burns down the whole forest. It's basically the analogy that you would use. And I think Jill's back, and maybe she can add more from by her side.
And my apologies, we had a little power bump, and I apologize for freezing and then trying to get back in. I didn't go to Rome in terms of you seeing the background. But I'm back and really agree. I've been listening to Mark's comments in terms of the needs for us to have a population, what we call population health, and really have more predictable, both reducing total cost of care and improving quality. We are very, very focused on trying to do that together and create those models that will help us be more efficient.
Okay, Senator.
I have a follow-up question related to vaccinations.
Yes.
When we do get them, and I think we need to prepare because it's going to be a big deal, and we know we're not going to get enough for everyone right off, the bat. But that being said, will active cases of COVID-19 be able to be vaccinated, or do they have to
Run its course.
run the course of the COVID first? Do we know that?
So, and I'll jump in, Mark, and you can jump in. Vaccinations are trying to prevent COVID. So you generally vaccinate a person that hasn't been exposed at that time to build the antibodies, so if they get exposed, they can fight it off. The best treatment right now for the patients who have got COVID is some of the treatments that are coming in terms of remdesivir and monoclonal antibodies, and there are ways that we can help them fight it once they have it. But vaccination is primarily focused on try to prepare so you can fight it and not get it. Mark, would you like to add to that?
No, I think that's correct. And I think it remains to be seen whether there'll be any role at all for vaccines in people who had COVID in the past. And we don't know the answer to that because we don't yet know the endurance of the antibody response that people get when they have had COVID. So, we know that when people have had COVID before, they generate antibodies. We don't know how protective those are exactly toward getting it again, and we don't know how long they last. And those are both important data points that we would need to decide if we would ever vaccinate somebody again who had COVID.
And the reason I ask is, again, because everyone awaits the vaccine. And we talk about who will be vaccinated first. I think, again, this comes down to communicating so that we don't have the masses trying to rush places where they're giving vaccinations who are really not supposed to be vaccinated, or it's not their time to be vaccinated. And I think that's one of the things that maybe we need to work with you guys in the medical community as to determine how the vaccine profile should look.
Absolutely.
Sure. No, absolutely. And phase 1A, the people who will get it first are going to be first responders.
Absolutely.
And then 1B, the next group will be high-risk people. So if you live in a nursing home, if you're above a certain age, if you have multiple comorbidities or other types of diseases, you would be next. And it's going to be a long time before we get past 1A and 1B.
Correct, but I want to make sure that the people out there know, because we're going to get inundated with people saying, I can't get vaccine from my mother who is a COVID-19 patient, and spend a lot of time trying to convince people that they're not supposed to be the ones in line for vaccine. So I'm just saying we need to get that communication piece ready.
I mean,
Absolutely.
It may be worth communicating what you've just said, Dr. Ugaishi, in the sense where when we do get a vaccine, the first two groups are going to be first responders and those in nursing. So, and just constantly repeat that now so that we're already setting up the expectation. Because I think Senator Kidani is right, is that we'll probably get a massive reaction from the public with a sense of urgency who would want the vaccine, and there's going to be a lot of frustration.
Absolutely, and that's why it's so important for us to educate right now and for all of us to keep wearing our masks, because it is prioritized to those who need to be available to take care of the sick and those who are most likely to have a very negative outcome in terms of mortality or morbidity. So, and that makes sense, you know, if we think about ourselves all as one community, one ohana, we want the persons that will most be impacted to get what they need first. Those of us that are healthy need to be wearing our masks. And I think we're one of the few communities, because of the Aloha, that will have the ability to do that. And what Mark was also mentioning when he said we don't know about how long the vaccine it works and how long it keeps the antibodies. Think about a flu vaccination. We get vaccinated every year for the flu, and we don't know yet with this virus what kind of cycle we will need after it. So working together to start with who is most impacted, which will take care of us, and the most who are likely to get sick is the first. And then we'll all, over time, get access to it, and we'll start to learn about its cycles and whether we have it once or twice if it's the messenger RNA vaccines, and then if we need to have it repeated in the future.
Senator Kim?
Thank you, Dr. Green. Thank you very much. You know, we're talking about masks, and it's still, I can't understand. I get calls and emails from people upset that, you know, we shouldn't be mandating masks, and that masks doesn't do anything. And so, you know, I know there's people out there that believe that, so I'm not sure how we can get that information out to people to let them know that in fact does help. So is there a way to show that in a group or large gathering, if you wear your mask, is there any kind of surveys that have showed, or data, statistics that have showed that in fact there has not been any kind of transmission when people are wearing the mask?
Mark, do you want to take that one?
Sure. There's really good scientific data that shows that masks are preventative, no question. But to get the full effect, both people have to be wearing it, the sender and the receiver.
Right.
So that's why when you're wearing the mask, it's not just that you're protecting yourself, in which case you could make the argument, if I don't want to be protected, maybe I don't have to wear it. You're protecting your community member, because it's basically, if you think about it in rules of 10, if there's like 100% chance that if Jill and I were talking to each other and we were only 3 feet apart and I was infected, I would infect her 100% of the time. If just I wear a mask and not her, it drops down to 10%. And if both of us wear a mask, it's 1%. So you know, that is the difference in everybody wearing a mask compared to like just if I feel like it, I'm going to wear a mask.
So you can still transmit in both of you wearing the mask, right?
By 1%.
Very small
Yeah.
percentage.
1%.
Now-
Very small, but
What
yes,
Right.
if you're both, and that's why physical distancing,
Right.
and that's why limit those gatherings.
Now-
What we're doing is just like having your seatbelts.
Right.
One person wears a seatbelt, another person in the car doesn't wear a seatbelt, one person's going to be harmed.
Right.
You're both wearing your seatbelts, that's better, but both using the seatbelt and all of the safety precautions when you drive prevent the accident. So we believe in multiple layers of safety. Masking does it, but keeping distance, keeping in areas that have good circulation, washing your hands, those are all ways that help us reduce the risk. And the gatherings are significant. They are, when the clusters frequently start in gatherings.
Now,
If
what about the
none,
type
we're-
of, Doctor, what about the type of mask? Because I've read that if you wear that stretchy mask that's like a little neck thing, that, you know, you're really not preventing it. And I went to a restaurant, and one of the cooks at the restaurant had that on, and I was hoping that he wasn't going to be on our table. Luckily, he wasn't, because I was worried that, you know, even with that kind of mask on, that they, it could be transmitted to the food that they were cooking. So is that a concern?
So there are different types of masks, and you'll see when you talk to the nurses that are taking care, or the doctors taking care of COVID patients, they have very specific masks that when you know the person has COVID, you're going to be in close contact, you need that N95 or the cappers. And
Right.
so
But
on
I'm
one
talking
side,
about
there are
in the
those
general
kinds of
public,
masks.
yeah.
Then there are people just putting something over their face. You really do want, if you're walking in the public, you want a mask that has 1 or 2 filters in it. We can get those over the counter. The cloth masks with some filters are very helpful. Again, keep your physical distance. In the hospitals, I use what's called a surgical mask because there's increased potential. So depending on the environment you're in, if you're wearing a normal mask with some filters, you're in a good position, particularly if you're keeping your distance and the other person is as well.
Got
Mark?
that, Dr. Green or Mark. So, but what I'm saying is that if we do a mask mandate, is it enough to just say you wear a mask or to determine the type of mask? Because again, if you have somebody handling food and they're wearing that kind of mask that I'm hearing that the virus can even spread more from that kind of mask, then are we really going to be, trying to minimize that by just saying, just cover your face? And I've seen people use their T-shirt and walk in the supermarket and stuff like that. I mean, so should we be mandating, if we go into a mask mandate?
Well, we do have a mask mandate
Right.
now. I mean, it's not
But
like we
I'm
don't
not
have one.
consistent, it's not
Yeah.
consistent,
Yeah.
that it'd be a type of
And it's not
mask.
descriptive,
Right.
like you're asking.
Yeah,
I
I mean,
guess-
I know it can't be completely descriptive, but we can say,
guess-
don't wear, these type of masks are not good or something.
So do we have to be prescriptive with material, with layers of cloth? I mean, does that all have to be in the, I think that's what she's asking, a gaiter versus,
A
Is that
general
even-
restriction, I
Yeah.
mean, because it's going to be hard to be so prescriptive.
We don't even wear masks.
Right, so I'm gonna go back to my comment about perfect being the enemy of good. So I think a mask mandate will be very, very, very helpful. But if you wait until you can get agreement about like what you're gonna put as the requirements for a mask, number one, it's gonna take you 3 months to pass such a thing, and then it's not gonna be useful during the holidays, and you're gonna have less compliance probably. So again, it might be not as useful that way.
Okay.
So, I mean,
Got
I
it.
think you balance all of that and you say, let's just go with, a mask mandate and just say, wear a mask in public statewide, and here are the exceptions, and there are very few, and here they are. While you're in a restaurant, while you're by yourself in a room, or whatever it is. I'm just making it up now, but something that's not perfect, but it's good. It's clear, it can be easily communicated, and it expresses the urgency of people to listen.
Good point, Doctor, thank you. Finally, I just want to bring up, I appreciate the graphic on showing where the spikes were, and like around 4th of July and so forth. And I know you said that it went down when the governors did the stay at home, but this is also related to the fact that we put up more contact tracers, because certainly back in August, when there was a spike and we found out they didn't have as many contact tracers, can that also be part of the spike?
Contact tracers are critical, and I heard we're up to close to 400 contact tracers, and you know why, and so we're right there with you that contact tracers are essential, because from the first moment we know that, let's say I unfortunately got COVID, from that first moment, if within a short period of time, 24 hours, 12 hours, if I am notified and that the contact tracer is getting all of my contacts and notifying them, what you're doing is containing the disease, containing the spread.
So we
So
brought
to
the
get-
curve down with the
Right.
more contact tracers, right?
So
Is what I'm trying to-
contact tracers can make a huge difference in stopping those clusters. So that's why it's so essential, and I've been really pleased this last 6, 7, 8 weeks where they are being very active. And the way we stop this next surge is wear our masks and have good contact tracers so that we can immediately test and screen and contact trace and get us all isolated, because it stops it from going from the 1.1, 1.2 to 1.4. It stops that rate of spread.
Can you,
The other thing that contact tracers are so important for is their work is the storytelling. So, you know, they can tell us where the spread is happening, and then you can tell stories around that actually can influence public behavior, right? If it's happening because of a party or because of a workplace gathering where people had a potluck instead of eating in their own space, all of those things, they educate people as to what's the right and wrong way to behave. And I just wanted to, from a personal standpoint, I wanted to thank this committee for your role in getting contact tracing up and running. I know I was screaming to anybody who would listen for many, many months that we need more contact tracers, and you guys got it done in a week, and you know, the state of Hawaii thanks you for that.
can you, so again, that's the cause and effect, right? Is it possible to bring up, Dr. Hoggard-Green, I think it's slide 7 from your presentation? Is it possible to bring that up?
Let's see if I can find it again after having that power issue.
Because it goes to what Senator Kim is saying, and it's a question I have regarding your projected holiday surge. You know, this spike is big, and so I'm assuming, and I'd like you to just comment, does this take into account the fact that we now have 400 contact tracers? Does it take into account the fact that a lot of the assumptions for a fall surge on the continent are because it's cold, and people go in more when it's cold, but it's not cold here? And does it also, that spike and then the rapid drop, I'm just gonna keep talking while you guys pull it up. Does that contemplate a shutdown? What are the assumptions being made on this spike in, it looks like beginning around Christmas and then hitting its peak toward the end of January? That's the one.
Yep. There we go. Okay.
So are you accounting for the fact that we have more testing capacity, that we have more contact tracers, that we should have better communication? You're still projecting this spike after taking all of that into account, and are you projecting a shutdown in order for us to get to the other side of that peak?
Yes. All right. So it does two things. So first, if you see that going down in February, that's where there's assumptions that we would do something, whether it's shutting down, reducing mobility. So that immediate spike going from January to February does have an intervention. The others do not. The November, December, January is if we aren't wearing our masks, we aren't doing contact tracing, so we've got a rampant spread of the disease during the fall. So everything you've just described, that's why I have a lot of hope and comfort, is we can manage this. Stop the spread with your mask. If you do have it, immediately have the contact tracers that can stop the spread by getting us isolated. All of those things will change that reality. So I firmly believe we can avoid that surge with the kind of good work that's already happened with your supportive contact tracers and the kinds of education that we mutually do together. That's why it's so important that we're sharing that same message.
Right, and as scary as this slide is, the last slide that Dr. Green closes with is the one of hope, right? Which is if we do all of those things, we get that bottom line, right? Which will not show that spike that she just showed, and that's why we have to strive for this bottom line here.
And I can appreciate, I can appreciate that you folks continually come back to the interventions. I think that the reason I came back to this in the end of because I guess we're going to wrap up soon. But the reason I'm coming back to it is I don't think there's been a sufficient discussion on our side, on the state side, about again, cause-effect intervention. You guys have talked about the cause, you've talked about the intervention. We need to have a meaningful discussion with the community, a real discussion about the effect. And because then for me at least, it makes the intervention make more sense. If we're not going to have the discussions you've been asking about, you've been asking to happen, Dr. Mugiishi, the discussions about the stories around these clusters and how these things get out of control around families, around workplaces, around lunchrooms. If we're not going to have those specific stories explained to the community, then we need to have a real discussion about the impacts of folks not following the mandate or the guideline or just whatever the consensus is on how we should all behave going forward. And I don't think that that's happened yet. And so this information, I think, is really important because then it justifies the statements that you folks are making now and have been making throughout. That's the only thing I wanted to say about that. Thank you.
Can I just add to that, too? Dr. Green and Dr. Mugiishi, thank you so much for this information because this is not something that we're getting, through our Department of Health or any of the agencies in the state. And because, the governor and Hawai'i and they're supposed to be all working together, have you shared this with them? Because I've not seen, and I don't know if you have seen any kind of risk management plan or the COVID-19 impacts plan and how to mitigate them in any kind of information like this. Have you guys been aware of anything that's come out?
And I think we're in frequent communication with General Hara, so I'm sure he cascades it down to his organization. The governor has communication people now working, for his administration, like Lori Teranishi, and she intersects with our Hawaii COVID collaborative to make sure we're trying to stay in sync with our communication plan. So, it might not be a direct, line that's there's a process for us staying in constant communication, but I don't think we're working in completely different silos either. Jill, I don't know what your thoughts are about that.
No, I agree with you, Mark. There's lots of conversations about, and we use the words very distinctly, we can control this. It's all about what we do. We all know that this virus will transmit if we aren't wearing masks. So it's just critically important that we share the message in many different ways, that we change behavior, and we are completely aligned with that. And again, with your good work and the way you've been communicating, the addition of the contact tracers, all of that will make a world of difference.
So I guess.
And I'll also just add that, Speaker Psyche decided to keep his COVID committee going. So, Jill and I are both on that, and, we try and share that also, which, not only ties back to government, but there's a lot of community people on that. So hopefully the word is getting out.
Yeah, and I think it's, how for us, it's very helpful to have this kind of information and in these graphs that you guys have given to us. But I think it would be also very, give our constituency and our members, our residents here in the islands some credit that they can understand some of this. And I'd like to see some things like this, put out in the media, whether it's through you guys or through your COVID-19 task force or through the governor or Hawai'i, however it's done. But this is a message that, it shows your graph, it shows your work, and if there's any way that we can be able to put it out, I'd appreciate that. Are we able to share this publicly?
So all of the information, yes. The issues with the Queens data is it's directed at Queens, so it doesn't represent all of the state. So as it comes to the surge, I'd like to work with you in a better way to show a whole statewide approach if you'd like that. And I shared it with you so that you have the information. We feel very comfortable with that information, meaning we think it's accurate if we don't intervene. But we know we're intervening. Yeah. So our messages from Queens are, we gotta stay vigilant. Whatever we need to do to stay vigilant is very important right now.
Thank you.
Right, and same with me, just some of the data is specific to HMSA, but I'm a pretty transparent person. I have no problem with people seeing it, and especially if it's gonna help them understand the impacts that this might have. And again, like Jill says, so let's get control of it so we can get past it.
Thank you.
Thank you.
Okay, if there's no further questions, thank you very much for your time. We really appreciate the information that you provided and your commitment to making Hawaii safe and secure. So we really appreciate all you guys have done. Mahalo.
Thank you.
Mahalo, and back to you. We agree.